Hello everyone, I'm Dr. Jiji George from Department of Oral Pathology and I'm today here to speak about osteosarcoma. So osteosarcoma is a malignant bone tumor. A sarcoma is a mesenchymal malignancy or a malignancy of the connective tissue, and an osteosarcoma in particular is a malignancy affecting the bone or the bone tissue. So the mesenchymal cells, which have the ability to induce osteoid or immature bone, is what osteosarcoma consists of. So before going into osteosarcoma, let's discuss about types of bone formation. Now, bone can form either uh, from the mesenchymal cells, that is called as intramembranous bone formation, or bone can form from cartilage cells, and that's called as endochondral bone formation. So the cartilage cells will get calcified and then form bone, that's endochondral, and the mesenchymal cells will convert themselves into osteoblast and secrete bone, that is intramembranous. So these are the two types of bone formation which you see in the human body. So depending upon where the site of the bone tumor that can arise, the osteosarcoma can be divided into intramedullary, that is from inside the medulla, arising inside the medulla, juxtacortical, that is just outside the cortex of the bone, adjacent to the cortex of the bone, that's basically called as periosteal, and then extraskeletal. Extraskeletal means it arises in areas other than the skeleton. That is, it arises in the soft tissues, other than the bone, in the soft tissues. So that is the classification of osteosarcoma depending upon the site of origin. Now comes the histological types of osteosarcoma. That is, for a pathologist, a clinician would just know the types of osteosarcomas which are clinically seen according to the sites. And the clinician would actually take a biopsy and send it to the pathologist for further diagnosis. So the pathologist is the one who decides what type of histological type of osteosarcoma it is. Now, the histological type of osteosarcoma will decide the course of treatment. So that is why it is important, the diagnosis is important for the surgeon. So we have osteosarcomas, which are osteoblastic. They're called as osteoblastic osteosarcoma. We have where there is bone formation. Now we have osteolytic osteosarcomas, where there is bone resorption predominantly. Then we have chondroblastic osteosarcomas, where you obviously find tumor osteoid, but then you have some chondroblastic elements, that is your cartilaginous elements as well. Then you have fibroblastic osteosarcomas, where you have a lot of spindle celled fibroblasts which are proliferating, and telangiectatic osteosarcomas. Telangiectasia means dilatation of the tail end of the vessels. That is called as telangiectasia. Ectasia means dilatation. So the osteosarcoma which shows a lot of blood vessels and a lot of vascularity is called as a telangiectatic osteosarcoma. So depending upon what you see on the slide, you classify the osteosarcoma to that particular histological type. Now, coming on to another type of classification, central and surface. Now, central is the osteosarcoma which you find affecting the bone, inside the bone, and surface is on the surface of the bone, on the outer part of the bone. So, depending upon where it is present, it is again subdivided into high grade and low grade. So, when I say high grade, the prognosis is going to be bad, and low grade means the prognosis will be better. So high grade or central type of osteosarcomas can again be subdivided into conventional, telangiectatic, small cell because you find small sized round cells, hematoxyphilic round basophilic cells in the osteoid. Then you have epithelioid type. Epithelioid, the word oid means similar. Epithelioid means a cell that is similar to an epithelial cell. So an epithelial cell will have a nucleus and a well-defined cytoplasm. And how an epithelial cell, it will be more of squamous in shape. So how an epithelial cell looks like is what an epithelioid cell will look like. That is mostly like a macrophage. Then you have osteoblastoma like osteosarcoma, where you have osteoblastic formation. I've already discussed before. Then you have chondroblastoma like osteosarcoma, that is where you have cartilaginous formation in the tumor osteoid. Then you have fibrohistiocytic type. Now, fibrohistiocytic type just means that you see cells like resembling histiocytes as well as fibroblasts. Then you have giant cell rich, where you have a lot of multinucleated giant cells along with the tumor osteoid. So, whatever type of the osteosarcoma it be, in histopathology, you will have to find atypical tumor osteoid. That is, tumor osteoid means it is neoplastic bone. And how will you understand it is neoplasia? Looking at the cellular features of malignancy. So the next we come to the low grade type of the central osteosarcoma. Now that is, and you also have fibrous dysplasia like osteosarcoma. So I have already discussed about fibrous dysplasia in a previous lecture. So fibrous dysplasia is a fibrosis lesion. So where osteosarcomas are more likely to arise if they undergo radiation. So such a osteosarcoma which arises from the fibrous dysplasia would look like a fibrous dysplasia like osteosarcoma. Then you have desmoplastic fibroma like osteosarcoma. Now, what is the word desmoplasia? Excess proliferation of collagen fibers is called as desmoplasia. So, in some cases, along with the tumor osteoid, you would find a lot of fibrous proliferation. So, coming on to the next entity, that is your surface osteosarcoma, which arises on the surface, not inside the bone. So, that again can be low grade, intermediate grade, and high grade. The low grade surface osteosarcoma is called as a perosteal osteosarcoma. I'll show you a picture later on. Intermediate osteosarcoma, that is a periosteal type. Now, periosteum is nothing but the outer covering of the bone. So, the outer covering of the bone has the periosteum, which again has subdivisions of into two layers. The inner layer is a cellular layer and the outer layer is a fibrous layer. So you have an outer fibrous layer of the periosteum, and then you have the inner cellular layer of the periosteum. So any osteosarcoma which arises from the periosteum can be an intermediate grade. Then you have a high grade of osteosarcoma, which is a dedifferentiated perosteal type. Now, the word dedifferentiated has already been explained in the chondrosarcoma lecture, which I meant to say that it is about going back from a more differentiated situation back to a more primitive situation. Now, what do you mean by differentiation? Functionally being, terminally, functionally maturing to a terminal function is called as differentiation. So, de-differentiation is going back to a more primitive stage where it does not have a particular type of function, defined function, specific function to carry out. So that is called as de-differentiation. Now, high-grade surface lesion would be seen on the surface, but highly, more aggressive, and the prognosis would be very poor. Now, intracortical, inside the cortex, within the cortex, and gnathic is jaw osteosarcoma. So, the osteosarcomas of the jaws, maxilla and the mandible, are separately classified as gnathic osteosarcomas. So, osteosarcoma again can be classified by the anatomic site. Osseous is when it is seen in the bone. Central, again, when it is seen inside the bone. Surface is when you see at the periphery. Gnathic when you see it in the jaws. Multifocal when you see it in various areas, a lot of sites. Soft tissues when you see it arising in something like a peripheral soft tissue like a tongue or something. Then intramuscular when you see it arising inside the muscles, and other osteosarcomas. So that's a very wide empirical classification of osteosarcomas. Coming on to clinical features. Now we would talk more, giving more importance and stress to the gnathic osteosarcomas, that is your jaw osteosarcomas. Now extragnathic ones show a bimodal age incidence, 10 to 20 years, and again it will peak at the 50-year age group. Now 10 to 20 years, perhaps because there's a pubertal growth spurt which takes place at the 10 to 20 years age group. So that can again be a reason for the peak of osteosarcoma occurrence in that age. And then you have a 50-year peak. So the second peak in older patients with is seen because it is seen in bones which are involved with Paget's disease and previous irradiation. So at that age, mostly patients would have, there would be a certain number of patients who have undergone treatment, radiation treatment for some other problems like Paget's disease. So anytime the bone is subjected to some kind of a radiation, there are chances that it can give rise to an osteosarcoma. Now, on the maxilla and the mandible, there are some particular sites where, as you can see, where you can get the osteosarcoma arising. Now, clinical features, otherwise, you will find swelling, pain, and facial deformities. Then you have loosening of the teeth. Obviously, loosening of the teeth, because if it affects the maxilla or the mandible, your socket is made up of bone. So if your socket is affected, obviously there'll be loosening of the teeth, because periodontal ligament will not have a proper attachment to the alveolar bone on one side. Then you can have paresthesia in case any of your nerves which are passing through your maxilla or your mandible are pressurized or are invaded by the sarcoma. Nasal obstruction, if the tumor grows into the nasal cavity. It is seen more in males than in females. Now, there can be a history of preceding Paget's disease or previous irradiation, as I already told you. Then you can have it have the perosteal one, or just outside the cortex, the juxtacortical one with a better prognosis, and a periosteal one with a aggressive variant. So the extraosseous osteosarcomas, as I said, can also be seen in soft tissues. Now, this is a textbook picture of the osteosarcoma, where you can see how do you explain this clinical picture. You can see that the intact mucosa is present on the swelling, and the swelling which you can see, you have to palpate and see whether it is firm or hard. It will be a hard swelling because it is inside the bone, and if it is a hard swelling, that means it is intraosseous in origin, and you can see a very intact mucosa, which goes on to say that there is no perforation of the lesion into the outer surface. So you can't see any visible inflammation on the mucosa, and it's a very clean oral cavity. So we know that it is nothing which has come from the external sources. It is something which has arisen inside the bone. So this is a clinical picture of osteosarcoma. Now, these are also clinical presentations of osteosarcoma. On to the left, you can see that perhaps the growth has perforated, and it has started affecting the outer portions. And there's already, you can see there's a loss of teeth, perhaps because the socket was affected and the tooth became loose and they mobile and they got lost. And in your picture to the right, you can actually see a bit of ulceration occurring in the retromolar area, which really clearly means that the osteosarcoma has either perforated from inside the bone, or it has arisen in the soft tissues. Now, this is the picture I spoke about that I would show to differentiate between the periosteal and the perosteal type of osteosarcoma. Now, this is a cross section of the mandible, and you can see that the mandible contains the medullary cavity that is in the center, and you have a cortex which is in the green color, and outside the cortex, this brown colored area is basically your periosteum. So one type of osteosarcoma is your perosteal osteosarcoma, which actually arises on top of the periosteum from the cortex, and the periosteum is not lifted out. It just goes out and it is seen on the surface of the bone, and there is no elevation of the periosteum. At the same time, if you look back into the periosteal type of osteosarcoma, you can actually see that that also arises from the same surface of the cortex, but then it lifts the periosteum high. So as a result of the periosteum being lifted high, on either sides, you can actually see reactive bone formation. So there is a difference between neoplastic bone formation and reactive bone formation. When I say reactive bone formation, it is just a reaction to some kind of a stimulus. But a neoplastic bone formation does not need a stimulus. It will keep on multiplying and proliferating, and it will obviously show features of atypia. So in this picture, you can see in red color, what you can see in red color is the neoplastic osteoid, and that's a tumor tissue. And because the tumor is elevating the periosteum, You can see a little bit of bone formation on either side under the periosteum. That is a reactive bone formation. So this is the difference that one has to understand. Now, radiographically, obviously, in the for a osteosarcoma, you will find very clear radiographic features. Now, always understand that all these lesions have a different picture in different phases of the patient reporting to you. Now it can be seen as a dense sclerosis, that is very thickened bone with radiopacity. You can see a mixed sclerosis where you can see alternatively radiolucent and radio-opaque lesion. It will be a mixed lesion. Or you can see a osteolytic lesion which could be radiolucent. So whatever be it, it will have a ill-defined peripheral border, because obviously it's a sarcoma. If it was a benign lesion, the capsule would have made it a limit, a very clear limit and well circumscribed area to the disease. But here, since it's a sarcoma, it's a malignancy. Obviously, the growth is very uncontrolled, so it has a ill-defined peripheral border. So you will not be able to recognize between where the normal bone is there and where the neoplastic tissue is there. So it will be just a blending border into the normal bone. So there will be a resorption of the root of the tooth in a tapering fashion called as spiking resorption. Now that's very important for you all to know, because usually cementum does not get resorbed very easily. Bone will resorb, but cementum does not resorb. Now, since this is a malignant tumor which is affecting that socket area, there are chances that it will cause resorption of the cementum as well. So that is called as a spiking resorption. Now, the characteristic radiographic appearance of osteosarcoma is called as a sunburst pattern. I will show a textbook picture later on in this lecture. So that is due to osteophytic bone formation on the surface of the lesion. Now, symmetric widening of the PDL is again a very characteristic feature that you see in osteosarcoma as well as chondrosarcoma. I said symmetric means equivalently the PDL space, the periodontal ligament space would widen due to tumor infiltrating that area. So this is basically seen in a gnathic osteosarcoma. Now, CT scans can be done to check intramedullary extensions, to see the depth of the tumor. That is, before when the surgeon takes up the surgery, he would want to know what is the extent of the tumor. What can he expect when he opens up the lesion? So which is why he goes in for a CT scan. So to check intramedullary extensions, tumor calcification, or cortex and soft tissue involvement. These are things which you can see in a radiographic picture of an osteosarcoma. Now, in histological picture, as I explained already, histological picture can be assessed by the different types of osteosarcomas. Now, histologically, there are different types of osteosarcomas that you see, depending upon what is the predominant tissue that you see in the lesion. It can be an osteoblastic osteosarcoma. If we find a lot of these mesenchymal cells which are undergoing atypical features, they produce tumor osteoid. You can see a chondroblastic osteosarcoma where there will be a lot of cartilage formation. Fibrohistiocytic osteosarcoma where you will find fibroblasts and histiocytes together in a mixed stroma along with the tumor osteoid. So by and large, you will find that the tumor cells are very bizarre. They can be round, spindle-shaped or pleomorphic cells. And always remember that any tumor cell will have aggressive cellular feature of malignancy, which I mean to say would be very hyperchromatic nuclei, and it would have a very irregular size and shape of the than the normal parent cell. So the bizarre features will be there, like a hyperchromatic deep staining nucleus, and it will be disorderly arranged. Now, these are some histological pictures which can help you to identify an osteosarcoma. As such, osteosarcoma also would need a lot of these immunohistochemical markers to find out whether it is an osteosarcoma or some other variation of the tumor. But then if you do a plain hematoxylin eosin stain, this is what you can see. So in the first picture, you can actually see that there is tumor osteoid formation here. The eosinophilic color that where I'm showing the cursor is your tumor osteoid. And then you can see that in the adjacent connective tissue, there are hyperchromatic spindle-shaped cells. So this prominent nucleus can be seen. So whenever the nuclear content is really high, we know that these are angry looking cells, which are actually highly atypical. So these are hyperchromatic, pleomorphic mesenchymal cells, which are actually the tumor osteoblasts. And they have given rise to this tumor osteoid. And in a typical fashion, there is lacunae. Some of the lacunae are seemingly empty, but then otherwise the lacunae have got the osteocytes entrapped in them. Usually the osteocytes are very small resting cells, but here you can see that they have a large nucleus, and they are very darkly stained, which means that a tumor osteoid will have atypical osteoblasts entrapped inside the osteoid as seen inside. Okay. So the other picture, that's an anaplastic tumor cell. You can call it anaplastic because you have a lot of bizarre qualities in them. Now the picture onto the lower part of your screen is basically again showing a lot of tumor osteoid. You can see that there is osteoid which is calcified over here, and you can see that this area is mesenchymal cells ready to form bone or osteoid in the adjacent area, and it has a little bit of cartilaginous component as well. So this is again another picture of histopathology of the osteosarcoma, where actually you can see that these small osteoid seams which are there, they're interconnected with each other, and you can see that the connective tissue intervening it is containing has a lot of these atypical tumor cells. So you can also see a lot of vascularity here. You can see these red colored areas. There are a lot of vascularity is also there. But then this is also a typical conventional type of an osteosarcoma. Now, this is again another example of osteosarcoma. This is very helpful for you because if you look at this on all the three sides, you can see normal lamellated bone. So all these lines that you can see in the lamellated bone are basically the lamellae or the incremental lines of deposition of the bone. And in the center, you can see a tumor osteoid. So the tumor osteoid is just blending into the surrounding connective tissue. So that's what I said. It will not have a proper border. The borders will be ill-defined. Whereas for the normal bone surrounding it, the borders are very well defined. So that's another example. Now this is yet another example where you can actually see that there is tumor osteoid forming, and you can hardly make out where the tumor osteoid is blending into the connective tissue, and the connective tissue adjacent to it is highly cellular, and all these cells are very pleomorphic, very bizarre, and showing very hyperchromatic pleomorphic nucleus. So this is also another picture of an osteosarcoma where tumor osteoid is present. Now here again you can see this is bone which is calcified, but this is a osteoclastic type of area, osteolytic area, because all these large cells that you can see, actually they are multinucleated osteoclasts. So wherever the multinucleated osteoclasts are there, you can see that there's a cup-shaped area. You can see a cup-shaped area where I'm moving the arrow. So this cup-shaped area that you can see is basically the Hauschip's lacunae, which have given up bay-like areas of bone resorption. And adjacent to it, you have the mesenchymal cells, where all these cells, where I'm showing the arrows, they're all pleomorphic and they're very hyperchromatic osteoblast. Now, this is a chondroblastic type of the osteosarcoma, where you can actually see that there's a lot of collection of chondroblastic cells, and you can see all these cells are chondrocytes. You can see how round and oval they are, and most of them are two together, and you can see the hyperchromatic nucleus and the pleomorphic appearance of the cell. So this is a chondroblastic osteosarcoma. So, and we also have very rare histological types which are not usually seen. One is small cell osteosarcoma, where along with the tumor osteoid, you would see some tumor cells which are very small and round in shape. Then you have epithelioid osteosarcoma, where you find epithelioid cells. You have telangiectatic, where you find vascular tissue. Giant cell rich, where you find osteoclast-like giant cells, and malignant fibrous histiocytoma-like osteosarcoma. Now, chondroblastic type will be seen in the jaws, because our maxilla and mandible originate apart from cartilage, and well differentiated type will show minimum atypia and abundant bone formation. That I've already told you, that as the differentiation becomes poorer, it will stop resembling the parent tissue, and when it stops resembling the parent tissue, which means that it has more of atypia and abundant bone formation. So this is what I spoke about, the sun ray pattern or the sunburst pattern. When you take an X-ray or the radiograph of the lesion, you can actually see these spike-like, um, radio opacities. So this is the sunburst pattern. So that is about today's lecture, that is osteosarcoma. Thank you so much for a patient listening.